Hello and welcome back to the channel. Well, this video is mainly intended for eye surgeons who are in training, and I would recommend a strong viewer discretion for all the surgical video presentations shown on this channel. Today I have come up with a case in which I am going to show phacoemulsification in a white cataract. This female patient is a young patient about 36 years of age, and she presented to us with raised intraocular pressure and white cataract in both her eyes, and she was also giving a history of long-standing use of dexamethasone eye drop. The pressures were controlled using intravenous mannitol and glycerol and topical anti-glaucoma drugs. After the pressures were controlled, then we have taken up the patient for surgery, and let's start. By this time, one side port has been made. Anterior capsule has been stained using trypan blue dye, and here I have started initiating the capsulorhexis. Well, my plan is to make a small mini rhexis first, and then after decompressing the bag, if needed, then we'll make the secondary rhexis. So now, using the micro rhexis forceps for a better control, I am gradually making a small rhexis. In these kind of cases, one can have small fluid pockets, so one has to be very careful that the rhexis doesn't go to the periphery. The mini rhexis is done, and now is the time to decompress the capsular bag, making one more side port for bimanual irrigation and aspiration. Well, if you like the videos on this channel, please do hit the subscribe button and share it with your colleagues and help the channel to grow. So back to the video, and I am using bimanual irrigation aspiration to just gradually move and remove whatever the loose cortex is there in the capsular bag. And this case is not that very intumescent. Still, I am trying to remove whatever capsular bag cortex is there, because many a times in my experience I have also seen that after the puncture of the anterior capsule, many times the liquid cortex doesn't come out. Still, in periphery there can be some fluid pockets from where the capsule just runs off to the periphery, and it's difficult to retrieve it back. So just taking my time to gradually remove whatever cortex I can remove. This video is purposely slowed down, and the maneuvers being done are also slowly done for better understanding. Now is the time to enlarge the capsular axis. Here I am using a micro Caesar through the side port to make a tangential nick in the anterior capsular margin, and then using the same micro rhexis forceps through the side port. This is a 23 gauge micro rhexis forceps and gives a very good control in these kind of cases. Chamber became shallow, so I am going to refill the chamber with HPMC. Care has to be taken that we don't inject the HPMC into the capsular bag. It's always done in the periphery over the anterior capsular margin. With multiple grabs of the capsule. Now I'm towards the end of the rhexis creation. These young patients, in these young patients, many a times the capsule is elastic, so one has to take care that it doesn't run to the periphery. Now is the time to make the main 2.8 phaco incision. A triplanar incision is planned using a steel keratome. No hydrodissection is needed, so straight to the phaco part. Here I am going to do a stop and chop technique. The nucleus is not very hard, it is of moderate grade, grade 3 I guess. So here I am doing a thin long trench in the center. The phaco power used here is about 45. Flow rate in sculpt mode is about 25. Vacuum is about 80. Now the nucleus is broken into 2 heminuclei, and now is the time to do the chopping maneuvers. The phaco settings are changed. In phaco 2, the vacuum here is about 350, flow rate 35, and power is about 45. One heminuclei is broken into 2 small heminuclei. Now the other heminucleus is just rotated in the proper orientation. The phaco is buzzed in the center, and again I could get very good chop and 2 heminuclei could be created. Now one small nuclear piece is being emulsified. I am not pressing too hard on the foot pedal because judicious use of the power has to be done. Too much pressure on the foot pedal would create a lot of chattering in the antechamber, and all these small nuclear fragments can go and hit the corneal endothelium. So the power should be used in a way that the nuclear pieces just move around the phaco tip and do not go and hit the cornea. So the phaco tip is just placed at one place, and the rest of the work is being done by the Sinskey hook. I don't normally use very sharp choppers, so I feel that this Sinskey does the job very well. The other nuclear pieces are being emulsified now. In these kind of cases, we don't have too much of epinucleus or cortex, so we should always take care that we don't use too much of the power, and we should also protect the posterior capsule because there is no cushion effect of the epinucleus in these cases. The third small piece is emulsified. Now is the time to remove the last piece. Here I have reduced the vacuum to about 300. flow rate 30. So this is the last piece I'm going to emulsify, and here is a difficulty which I am facing. I'm not able to hold this piece, and this piece is just moving around in the entry chamber. So I plan to come out and in a moment I'm going to inject some viscoelastic. See, it is just moving here and there. I'm not able to hold it. The fallibility is not very good. And I am worried I might hit the posterior capsule, so I came out, inject some viscoelastic into the entry chamber. This would provide some resistance to the movement of the nuclear piece. And this time the SINSKI just pulls the nucleus piece towards the phaco tip, and gradually it is emulsified. One more small piece is there which will be emulsified in a second. That's it. The nuclear management part has been done. Very little cortex is there, which I am going to be removing using BIMANUAL irrigation aspiration system. In my BIMANUAL irrigation aspiration system, the bore of the irrigation handpiece is bigger and the aspiration handpiece is smaller. The irrigation handpiece is about 21 gauge and aspiration is about 23 gauge. So the fluid goes more in the eye, and that also helps in forming the entry chamber nicely. Don't have too much of shallowing even in small incision cases. So time to implant the intraocular lens. The bag is filled with HPMC. One should also take care that the draping is also very good. There should be no eyelashes in the field. No eyelashes should be touching the cornea, because majority of the time it is seen that the roots of the eyelashes have got potential source of infection. So no instrument should be touching the eyelashes while they are entering in the eye. These are all small things one should take care. Like one can see, there is very nice draping. I'll make a video of eye draping also for new residents, new surgeons, to learn the proper way of eye draping. The bag is now filled with the viscoelastic and the intraocular lens has been placed already. Now is the time to remove the viscoelastic. First from behind the intraocular lens. Here the vacuum is about 450, flow rate 45, bottle height is about 110. One should always remove all the viscoelastic from the eye before closing, because at any point of time we don't want any post-operative pressure spikes. Some intracameral moxifloxacin is instilled, and time to close now. Some final wash is done. Main port is hydrated. First the roof is hydrated, then the sides are hydrated. This is a 27 gauge cannula which has been used to hydrate the main port and the side ports. That's it, the case is done. Hope do you like the video and the narration. Do like, share and subscribe to the channel for more updated videos, and don't forget to press the bell icon so that you get the notifications of all the videos, all new videos whenever I'll upload them. Thank you so much. Have a nice day. Thanks for watching.